Dear colleagues and learners, as we begin this lecture on advanced cardiac life support and the evolving approaches to cardiac arrest management, I will guide you meticulously through each crucial detail. Welcome to this comprehensive, step-by-step exploration of current principles and practices in cardiac arrest management. We will journey through essential guidelines, evidence-based treatments, and evolving strategies that shape the modern approach to resuscitation and post-arrest care. From understanding the rationale behind the shift from ABC to CAB, to optimizing CPR quality, employing targeted temperature management, and tailoring advanced interventions based on individual patient needs, each segment is crafted to deepen your knowledge and confidence. Prepare to engage with a wealth of information that will empower you and your team to deliver the highest standard of care in the most critical moments. Links in the chain of survival, immediate recognition of cardiac arrest and activation of EMS system, early CPR with emphasis on good compressions, rapid defibrillation, effective advanced cardiac life support, integrated post-cardiac arrest care, including therapeutic hypothermia. EMS systems that effectively implement these can achieve witnessed VF cardiac arrest survival of almost 50%. Cardiocerebral resuscitation, CCR, new concept emphasizing high quality, minimally interrupted CPR to maximize blood flow to the brain. CAB is the new algorithm, as opposed to the previously taught ABC, because of the realization that arterial oxygen saturation remains high for the first 510 minute of a cardiac arrest. That recoil of the chest during chest compressions improves oxygenation, that delaying a definitive airway increases survival, and that high-quality compressions increases survival. Caveat: because children usually die as a result of asphyxial and respiratory complications, ventilation should be emphasized for them, and so the ABCs are still the most appropriate algorithm for the majority of pediatric cardiac arrests. BLS changes from 2005 guidelines, compressions before giving breaths, and pulse checks 10 seconds or less, faster compressions, at least 100 compressions a minute, i.e. 30 compression cycle in 18 seconds or less, deeper compressions, adults, at least 2 inches, children, infants, at least 1/3 the depth of chest. 3-phase model of resuscitation, electrical phase, first few minutes after the cardiac arrest, disorganized cardiac activity with minimal ischemia, requiring prompt defibrillation, circulatory phase, 610 minute, ischemic insult and injury developing, requiring uninterrupted compressions before defibrillation is attempted, as the heart needs to be upprimed for defibrillation with compressions. Metabolic phase, 10 minutes and after, therapeutic hypothermia and vasopressors may help in post-cardiac arrest syndrome. Carbon dioxide, capnography, end-tidal CO2, continuous quantitative waveform capnography, serves 3 purposes in initial resuscitation, helps confirm endotracheal tube placement and monitoring displacement, helps monitor quality of CPR, if EtCO2 40 mm, less than 10 mm of mercury, patient likely needs faster or harder CPR, although epinephrine may lead to decrease in EtCO2 level, detects ROSC, return of spontaneous circulation, with abrupt and sustained increase more than 40 mm of mercury. Pearls, bedside ultrasound should only be used in restricted situations during cardiac arrest resuscitation, in order to determine whether the heart is still beating in light of a potentially reversible cause of cardiac arrest, e.g., pneumothorax, cardiac tamponade, hypovolemic shock, and which would prompt you to continue resuscitative efforts. Minimize pre-shock pause between the last compression and defibrillation to increase success. Ventilation at high respiratory rates, 25 breaths per minute, is common during resuscitation from cardiac arrest. The guidelines say to deliver ventilations at a regular rate, 1 breath every 6 to 8 seconds, 8 to 10 breaths a minute, without interruption of chest compressions. Ventilating faster will decrease venous return and decrease cardiac output, especially in patients with hypovolemia or obstructive airway disease. The upper limit of the rate of sinus tachycardia is determined by the 220 minus the age of the patient. The starting dose for synchronized cardioversion in the setting of atrial fibrillation is now to start at 120200J. Instead of the previous recommendation of 100120J, remember the HS and TS, along with their respective treatment. Hypovolemia, fluid, pressors, hypoxia, oxygen, hydrogen ion, NaHCO3 only in certain situations, hypokalemia, potassium or calcium, insulin and glucose, hypothermia, rewarming. Tension pneumothorax, needle thoracostomy, cardiac tamponade, pericardiocentesis, toxin, antidote, thrombosis, thrombolytic if pulmonary embolus, thrombolytics or cath lab if myocardial infarction. Pharmacology, atropine for asystole, not recommended in asystole and PEA anymore, not due to negative studies, but rather to the realization that the evidence was always weak and therefore shouldn't be considered positive. Atropine for bradycardia may increase ischemia in the setting of an MI, doesn't work in transplant patients and is unlikely to work in patients with second-degree type 2 and third-degree block. Adenosine for wide complex tachycardias, on top of stable narrow complex. Regular tachycardia. The 2010 guidelines recommend using it in stable wide complex regular, i.e. monomorphic, tachycardia as well as a diagnostic approach, given that it might unmask SVT with aberrancy but won't do much for VT. Beware of the irregular, i.e. polymorphic, wide complex tachycardia, which may mask an alternative pathway such as Wolff-Parkinson-White's, in which case adenosine may precipitate VF. Reduce the dose of adenosine to 3 mg in post-cardiac transplant patients, those taking dipyridamole or carbamazepine, and when administered via a central vein access, amiodarone or procainamide for stable VTAC. The former has been shown in small studies to terminate dysrhythmias in only about 30% of cases. And latter, as much as 80%, patients receiving either should be monitored for QT prolongation and hypertension, and should never receive both medications due to the risk of refractory bradycardia and or hypertension. NaHCO3, sodium bicarbonate, in cardiac arrest, should not be used routinely because of resultant paradoxical intracellular acidosis, but may be considered in known or suspected hyperkalemia, e.g., dialysis patient, TCA overdose, or documented pre-existing metabolic acidosis as a cause for cardiac arrest, inotropes for bradycardia, dopamine, 10 microgram per kilogram per minute or epinephrine 2 to 10 microgram per minute drips may now be given as an alternative to transthoracic pacing, as a bridge to transvenous pacing. Post-cardiac arrest care, getting the pulse back is just the beginning. Avoid SpO2 of 100% because it leads to increased production of harmful free radicals and increases mortality. Aim instead for 94%. Avoid hyperventilation, which leads to hypocarbia and resultant cerebral vasoconstriction, which will worsen brain injury due to the decreased cerebral blood flow. Also avoid hypertension. Activate emergency PCI for post-arrest STEMI, and strongly consider for suspected high-risk and STEMI. PCI and therapeutic hypothermia can and should be done together. Thrombolysis should be considered on an individual basis when PCI is not available. There is a theoretical increased bleeding risk when thrombolysis is combined with therapeutic hypothermia. Therapeutic hypothermia, TH, at a good resource, www.nychypothermia.org. O reduces or stops destructive pathways such as cerebral edema and free radicals formation, which are caused by reperfusion after ROSC, has been shown to increase survival to hospital discharge with good neurological outcome, NNT of 6.0. Although strong evidence, i.e. RCTs, is available only for VF-IVT as presenting rhythms, the 2010 guidelines recommend TH in PEA and asystole based on positive observational studies. TH should not be done in cardiac arrests resulting from trauma because it will worsen coagulopathy in a hypovolemic and bleeding patient, as well as in vasopressor-resistant severe cardiogenic shock. Controversial, because the cold will make the myocardium less responsive to drugs. Cooling should be started as soon as possible in the ED, not in the ICU, with cooled for saline boluses 30 cubic centimeters per kilogram or 2L, with pressure bags, and ice packs to the axillae, groin, and neck, even if the patient will go to the cath lab. Goal of 3234 degrees C within 6-8 hours. Patients need to be adequately sedated, midazolam, fentanyl, but paralysis should only be used to prevent shivering, which often stops below 33.5 degrees Celsius because it may mask seizure activity, which is rendered more likely by ischemic brain injury. Consider the following initial ventilation settings: tidal volume of 6-8 ml. Kilogram with rate adjusted to obtain an end tidal CO2 of 3540 mm/Hg and FiO2 adjusted to obtain arterial saturation of 94%, also prevent hyperventilation and hypocarbia. Prognostication cannot be accomplished until 72 hours after the cardiac arrest, which is later than what used to be done in the pre-cooling era. Shock refractory VF, minimize the perishock pause, stop chest compressions only to assess for defibrillation and to defibrillate. Perishock pauses less than 20 seconds in the early resuscitation period are associated with survival to discharge when compared to episodes with perishock pause more or equal to 40 seconds. Tips to minimize the perishock pause: pre-charge the defibrillator during chest compressions, count down before pausing for a shock so that the shock is delivered in between chest compressions and the hands come off the chest only momentarily. Use a look-through monitor whereby the cardiac rhythm can be identified while chest compressions are ongoing. Dual shock therapy for refractory ventricular fibrillation. Dual shock therapy, double defib or double sequential defib, involves defibrillating patients who are refractory to multiple defibrillations with two defibrillators at the same time or within seconds of each other, one with pads set up in the traditional anterior positions and the other set up with anterior-posterior pad positions. A recent observational case series showed improved rates of ROSC with dual shock therapy with one patient surviving to hospital discharge. An RCT in 1989 by Bardi randomized patients with refractory ventricular fibrillation to dual VS single shock therapy and found no significant difference in ROSC, despite the lack of definitive evidence that dual shock therapy improves survival. We recommend attempting it when other avenues have been exhausted in the patient with refractory ventricular fibrillation. Stop epinephrine after 3 doses or lower the dose. During refractory ventricular fibrillation and VF storm, there is a huge catecholamine surge that contributes to the refractoriness. Rather than adding more catecholamine with epinephrine, our experts recommend stopping the epinephrine after 3 doses or lowering the dose in ventricular fibrillation. Some experts believe that the dose of 1 mg every 3 to 5 minutes that is recommended in the guidelines is too high, is too frequently given and may be detrimental. Epinephrine, in the doses used in cardiac arrest, causes cerebral vasoconstriction that may impair tissue oxygenation, brain perfusion, and compromise neurological recovery. In most patients with ventricular fibrillation, the primary cause is cardiac ischemia. Some experts believe that we should lower the dose of epinephrine in patients with ventricular fibrillation to minimize the vasoconstriction of the coronary arteries caused by epinephrine. Block the catecholamine surge with Esmolol. Esmolol is a fast-acting B-blocker that increases the fibrillation threshold. Damaged myocardial cells are more sensitive to sympathetic tone, which Esmolol blocks. No medication, including epinephrine, has ever been shown to increase survival to hospital discharge, but Esmolol has shown some promising results. Esmolol was shown in a small study to double the rate of ROSC from about 1/3 of patients to 2/3 of patients, and to increase survival to hospital discharge with good neurological function from 11% to 50%. Larger studies are needed to confirm these findings, but so far the evidence looks promising. Esmolol dosing in refractory VF, 500 micrograms per kilogram for push, followed by infusion starting at 50 micrograms per kilogram per minute. Optimizing pulse checks. Detection of ROSC. Pulse checks are only needed if an organized rhythm is seen on the monitor. Manual pulse checks have been shown to be insensitive, not specific, and have poor inter-rater reliability. One study showed that rescuer pulse palpation was only 78% accurate. Even if a pulse is felt, this does not guarantee adequate perfusion to vital organs. For approaches to detecting ROSC and optimizing pulse checks can be considered. POCUS. Have a dedicated experienced provider look on POCUS for a carotid pulse during chest compression, so that as soon as a pause in chest compressions to assess for cardiac rhythm occurs at the end of 2 minutes of compressions. The pulse can be rapidly assessed along with the cardiac rhythm in less than 5 seconds, as opposed to less than 10 seconds as recommended in the guidelines, or have a dedicated experienced provider look on cardiac POCUS in the epigastric for brisk cardiac activity. Do not stop for a pulse check at all. Chest compression should continue until the end tidal CO2 monitor shows persistent elevations of more than 30 to 40. An early established arterial line shows persistent diastolic blood pressure more than 30 to 40. Oxygen saturation from a finger probe shows a persistent waveform. Pulseless electrical activity, PEA arrest. The ACLS guidelines continue to recommend running through the HS and Ts in order to arrive at a specific diagnosis and guide treatment in PEA arrest. This approach may not be ideal because the HS and Ts are difficult to remember in the heat of a stressful resuscitation, and some of the HS and Ts are rare causes of PEA, hypoxia, hypokalemia, and hypoglycemia, or are obvious, hypoxia, hypothermia. In contrast, a novel approach to PEA arrest focuses on the more likely diagnoses that require immediate treatment beyond your CABS to achieve ROSC. This way of thinking about PEA combines initial ECG morphology with the clinical scenario to guide the clinician to the most likely causes, and offer further diagnostic certainty using point-of-care ultrasound, POCUS. The first key step is to distinguish between narrow complex and wide complex PEA, with POCUS being used to help differentiate the causes of narrow complex PEA in particular. Ideally, a designated team member provides the specific POCUS role independent of the other team members. Adjust epinephrine dose. If you see a vigorous heart on POCUS, rather than administer 1 amp of crash cart epinephrine, consider push-dose epinephrine guided by blood pressure. Take a 10 ml syringe with 9 ml of normal saline. Into this syringe, draw up 1 ml of epinephrine from the cardiac amp. AMP contains epinephrine 100 micrograms per milliliter. Now you have 10 ml of epinephrine 10 micrograms per milliliter. Administer 0.5 to 2 milliliters every 1 to 5 minutes, 5 to 20 micrograms. A titrated epinephrine infusion is another option, titrating to diastolic BP, as described in the Paradis study in JAMA, requires early placement of an arterial line during ongoing chest compressions. The recommended chest compression rate is 100 to 120 per minute, which is updated from the at least 100 per minute. The recommended chest compression depth is 5 to 6 centimeters or just over 2 inches, but not more than 6 centimeters, as too deep can be harmful. Use audio-visual devices such as metronomes and compression depth analyzers, which can be used to optimize CPR quality. The routine use of impedance threshold devices, ITDs, alone or mechanical chest compression devices alone are not recommended. However, in out-of-hospital situations where manual compressions are difficult due to physical space limitations, mechanical devices may be useful. A recent RCT suggests that the use of the ITD plus active compression decompression CPR is associated with improved neurological intact survival for patients with out-of-hospital cardiac arrest. ECMO or eCPR may be considered for selected patients with refractory cardiac arrest where a reversible cause of cardiac arrest is suspected. Vasopressin has been removed from the algorithm altogether, and an emphasis on early administration of epinephrine is stressed. Ultrasound has been added as an additional method for helping to confirm ROSC and for confirming ETT placement. Use maximum inspired oxygen during CPR, and then after ROSC, titrate oxygen to an oxygen saturation of 94%. Rather than continuing maximum oxygen delivery, a low-end tidal CO2 in intubated patients after 20 minutes of CPR is associated with a very low likelihood of survival, and this factor should be used in combination with other factors to help determine when to terminate resuscitation. The routine use of lidocaine after ROSC is not recommended. However, the initiation or continuation of lidocaine may be considered immediately after ROSC from ventricular fibrillation or pulseless ventricular tachycardia. Emergency PCI is recommended for all patients with STEMI and for hemodynamically or electrically unstable patients without ST elevation for whom a cardiovascular lesion is suspected. To targeted temperature management, recommendations have been updated with new evidence suggesting that a range of temperatures between 32 and 36 may be acceptable to target in the post-cardiac arrest period, and an emphasis on fever prevention and treatment is stressed. CCR rather than CPR, CAB rather than ABC. Before we jump into the controversies, it's important to understand the basic theory of how best to achieve meaningful survival in the cardiac arrest patient. The concept of cardiocerebral resuscitation rather than cardiopulmonary resuscitation, emphasizing high quality, minimally interrupted chest compressions to maximize blood flow to the brain, an important theoretical determinant of long-term survival. Circulation airway breathing as opposed to the classic airway breathing. Circulation is how we should approach these patients because of the realization that arterial oxygen saturation remains high for the first 510 minute of a cardiac arrest. That recoil of the chest during chest compressions improves oxygenation, that delaying a definitive airway increases survival, and that high-quality continuous compressions improve survival. Caveat: because children usually die as a result of asphyxia and respiratory complications, early ventilation should be emphasized in the pediatric population. Determinants of good quality CCR: the recommended rate of chest compressions of 100 to 120 per minute, aiming for 110 per minute with audio-visual feedback such as a metronome, which is easily activated on most defibrillators, and the recommended depth of compressions is 5 to 6 centimeters with visual feedback, which is also easily activated on most defibrillators. These recommendations are based on observational studies from the Resuscitation Outcomes Consortium (ROC) papers. The guidelines suggest a compression-to-breath ratio of 30 to 2. However, in Seattle, the survival rates for cardiac arrest overall have remained around 19 to 20%, and for ventricular fibrillation are 44%, the highest in the world. Possible, in part due to a revision of the compression-to-breath ratio. Rather than the recommended 30 to 2 compression-to-breath ratio, in Seattle, the paramedics provide continuous chest compressions. On the 10th compression, the provider handling the breathing gives a single 500 cubic centimeters breath in between compressions, without any pause in compressions. The only time that Seattle paramedics pause compressions is to shock the patient, and even then, once they have determined that the patient is in ventricular fibrillation. While continuing compressions, they count down out loud and pause compressions for only a single, hands-off beat to re-administer a shock every 15 compressions until signs of ROSC are apparent. Experimental data out of England shows that, using gloves, the maximal energy delivered to a provider providing hands-on compressions without any pause for defibrillation is less than the average household electrical current, suggesting that hands-on defibrillation may be safe. In order to minimize compression pauses for pulse checks, our experts recommend two approaches. Have a dedicated experienced provider feeling for a manual femoral pulse during chest compression so that as soon as a pause in chest compressions to assess for cardiac rhythm occurs at the end of 2 minutes of compressions, the pulse can be rapidly assessed along with the cardiac rhythm in less than 5 seconds, as opposed to less than 10 seconds as recommended in the guidelines. Do not check for the pulse at all. Chest compression should continue until the patient shows signs of life such as respiratory effort, or until your end-tidal CO2 monitor shows persistent elevations. The argument here is that palpating for a pulse has been shown to be insensitive, not specific, and have poor inter-rater reliability. One study showed that rescuer pulse palpation was only 78% accurate. Even if a pulse is felt, this does not guarantee adequate perfusion to vital organs. Dr. Morrison suggests stopping chest compressions only to assess for defibrillation and to defibrillate. Simulation training and cardiac arrest teams. Simulation training plays an important role in optimizing performance of cardiac arrest teams. Like NASCAR tire replacement teams, the cardiac arrest team should be proficient at performing their specific dedicated tasks. Observational data from the Resuscitation Outcomes Consortium (ROC) show that the larger the cardiac arrest team, the better the outcome. Whereas previous guidelines focused on developing the skills of the leader of the resuscitation, current trends are to develop skills of each individual on the cardiac arrest team. The role of capnography in cardiac arrest. ETCO2 capnography is mandated in the guidelines to be used to confirm endotracheal intubation with an increase in ETCO2, assess the quality of chest compressions with an ETCO2 goal of 12 to 15, an ETCO2 of less than the 10th of may be an indicator of suboptimal chest compressions. An increase of ETCO2 35 to 40 may indicate adequate tissue oxygenation and can be used to confirm return of spontaneous circulation, ROSC. However, our experts recommend continuing CPR after the initial spike of ETCO2. Pitfall: stopping chest compressions immediately after an ETCO2 of 35 to 40 is recognized. The role of chest compression devices in cardiac arrest. In multiple randomized control trials, chest compression devices have not shown superiority to good quality manual chest compressions. The guidelines recommend considering the use of compression devices in environments where manual compressions may be difficult or impossible due to physical constraints, e.g., small cabins of some rescue helicopters. Impedance threshold devices, ITD, are circulatory devices which are applied to the endotracheal tube, ETT, or the bag valve mask, BVM, and increase perfusion to the right side of the heart. The ROC performed a study where they randomized patients to ITD versus sham ITD, which showed no superiority of the ITD. Antiarrhythmic medications in refractory ventricular fibrillation. There has never been an antiarrhythmic medication that has shown any long-term survival benefit in cardiac arrest. Amiodarone 300 mg for bolus is still recommended as the antiarrhythmic of choice for refractory ventricular fibrillation. In one study from the 1990s comparing amiodarone to placebo in refractory ventricular fibrillation, a higher rate of ROSC was achieved. In a study from the NEJM out of Toronto, pre-hospital ventricular fibrillation patients were randomized to amiodarone versus lidocaine, and amiodarone showed a higher rate of ROSC compared to lidocaine. However, the death rate in hospital in the amiodarone group was higher than that of the lidocaine group. Overall, survival at discharge from hospital was similar in both groups. The amiodarone versus lidocaine versus placebo (ALPS) trial is currently ongoing with a projected release in early 2016. Dual shock therapy for refractory ventricular fibrillation. Dual shock therapy involves defibrillating patients who are refractory to multiple defibrillations with two defibrillators at the same time or within seconds of each other, one with pads set up in the traditional anterior positions and the other set up with anterior-posterior pad positions. A recent observational case series showed improved rates of ROSC with dual shock therapy with one patient surviving to hospital discharge. An RCT in 1989 by Bardi randomized patients with refractory ventricular fibrillation to dual VS single shock therapy and found no significant difference in ROSC. It is unknown based on current evidence whether the improved rates of ROSC with dual shock therapy are due to chance alone or due to the increase in energy or multiple vectors of energy delivered to the heart. Dual shock therapy for refractory ventricular fibrillation is not recommended in the guidelines. Despite the lack of evidence that dual shock therapy improves survival, our experts recommend attempting it when other avenues have been exhausted in the patient with refractory ventricular fibrillation, epinephrine and vasopressin in cardiac arrest. There has never been a vasopressor medication that has shown any long-term survival benefit in cardiac arrest. Epinephrine has been shown in RCTs. To improve rates of ROSC and admission to hospital, however, one large pre-hospital study of Japan, while also showing improved rates of ROSC, showed worse 1-month survival rates with epinephrine. Optimizing epinephrine in cardiac arrest. Multiple factors may contribute to the effectiveness of epinephrine in cardiac arrest: timing, dose and frequency of administration, underlying rhythm and suspected diagnosis. Timing. The guidelines recommend administering epinephrine as early as possible in the resuscitation. Observational data suggests that the first dose of epinephrine is administered at 22 minutes on average after cardiac arrest. Some experts believe that earlier administration in the first 4 minutes during the circulatory phase of cardiac arrest may improve long-term outcomes, but there is only observational data for this in the literature. One observational study of cardiac arrest with non-shockable rhythm compared epinephrine given at 1 to 3 minutes with epinephrine given at 3 later time intervals, 4 to 6, 7 to 9, and greater than 9 minutes. The study found an association between early administration of epinephrine and increased ROSC, survival to hospital discharge, and neurologically intact survival. Dose and frequency of administration. Some experts believe that the dose of 1 mg every 3 to 5 minutes that is recommended in the guidelines is too high a dose, is too frequently given and may be detrimental. Epinephrine, in the doses used in cardiac arrest, causes cerebral vasoconstriction that may impair tissue oxygenation, brain perfusion, and compromise neurological recovery. Scott Weingart describes titrating epinephrine in cardiac arrest to hemodynamic parameters and end-tidal CO2. While end-tidal CO2 is an excellent marker for chest compression quality and determining ROSC, titrating epinephrine to end-tidal CO2 goals have never been shown to be associated with long-term outcomes. A physiologic measure of brain oxygenation called near-infrared spectroscopy may be a better marker to titrate epinephrine to in cardiac arrest, but currently there is no evidence in the literature to support its use. Underlying rhythm and suspected diagnosis. In most patients in ventricular fibrillation, the primary cause is an MI. Some experts believe that we should lower the dose of epinephrine in patients with ventricular fibrillation as the primary rhythm during cardiac arrest to minimize the vasoconstriction of the coronary arteries caused by epinephrine given at 1 mg every 3 to 5 minutes in patients with non-shockable rhythms, PEA, asystole. Early administration of epinephrine may be more beneficial than in patients whose presenting rhythm is ventricular fibrillation. Epinephrine versus vasopressin in ACLS guidelines. 2015, cardiac arrest. Vasopressin is difficult to draw up compared to the pre-filled epinephrine syringes and has not been shown to be superior to epinephrine in terms of survival benefit in cardiac arrest patients for out-of-hospital cardiac arrest. It has therefore been removed from the guidelines. The guidelines do state that vasopressin may provide some benefit when administered with steroids and epinephrine in treating in-hospital cardiac arrests. However, routine use of this bundle is not recommended. This was based on a controversial study in 2013 out of JAMA in Greece, with 268 patients showed that the combination of vasopressin, epinephrine, and steroids significantly improved survival to discharge with good neurological outcome compared to only epinephrine and placebo. However, our experts suggest that due to methodological flaws in the study, they cannot recommend its routine use as per the guidelines. Maximizing high-quality chest compressions in cardiac arrest. Perhaps the most important aspect of cardiac arrest care is providing high-quality chest compressions with a depth of at least 5 centimeters, but no more than 6 centimeters, a rate of between 100 and 120 compressions per minute, allowing full chest recoil between compressions and minimizing interruptions. The goal is near continuous compressions that pause only for defibrillation and brief pulse checks. Good neurologic outcomes after out-of-hospital cardiac arrest, OHCA, correlates well with target ranges of chest compression rate and depth, strategies to ensure high-quality chest compressions and minimize pauses in chest compressions. Feedback monitor devices for rate, depth, and recoil of compressions, metronome for rate of compressions. Smartphone metronome is a poor person's feedback monitor device. Dedicated chest compression coach. Note that chest recoil is difficult for the coach to assess, changing chest compressors every 2 minutes. Even fit chest compressors tire after 45 seconds of constant high-quality chest compressions. tend to slow down and have poor chest recoil, pre-charge the defibrillator. Before pausing chest compressions, reduces perishock pause. Count down from 10 before pausing chest compression so that every team member is ready to immediately defibrillate or perform a pulse check. Transesophageal ultrasound may help to locate the optimum location on the chest to maximize compression of the heart with each chest compression. Poker's pulse checks. The Poker's pulse is more accurate and as rapid compared to the palpation technique at determining whether or not a patient has a pulse. Ensure that the Poker's probe is optimally placed on the patient with adequate gel well before any pause in chest compressions. Arterial line. To assess for the presence of a pulse. Generated from chest compressions and guide resuscitation. Mechanical chest compression devices. A mechanical chest compression device is better than manual compressions. Advantages of mechanical CPR. Ensures high-quality chest compressions performed consistently. Cognitive offloading so team can concentrate on other aspects of resuscitation. Decreases interruptions to compressions. Allows defibrillation while chest compressions are ongoing. Eliminates perishock pause. Allows for consistent prolonged CPR in patients with prolonged extrication time at the scene, being transferred long distances and in hypothermia victims. The studies comparing mechanical CPR versus manual CPR suggest that outcomes are better with mechanical CPR for in-hospital cardiac arrest, while for out-of-hospital cardiac arrest the evidence is mixed. For highly skilled resuscitation teams, mechanical CPR does not seem to have any advantage over manual CPR. Training teams on placing and initiating mechanical CPR machines rapidly without pause in chest compressions is a prerequisite for using these devices, as inexperience with this will likely lead to a prolonged pause in chest compressions. Bottom line, for patients who require time-consuming extrication at the scene, for those with hypothermia-related arrest, for those who require long transports with ongoing CPR. And when skilled resuscitation teams are not present, mechanical CPR may be preferred over manual chest compressions. Defibrillation, pad position contact and dual sequential defibrillation for refractory ventricular fibrillation. Pad placement for defibrillation. The key concept when it comes to pad placement is that as long as the heart is in between the pads so that the vector of energy goes through the heart, the precise location of the pads does not matter. Nonetheless, our experts prefer the sternum apex or right anterior left lateral placement of pads over the anterior posterior sandwich placement of pads in cardiac arrest because it minimizes pauses in chest compressions. The patient needs to be rolled over in order to place the posterior pad for anterior posterior pad placement. Skin contact for defibrillation. Perhaps more important than the pad placement is ensuring adequate contact on the skin. In patients who are hirsute and/or sweating profusely, consider handheld defibrillation paddles to ensure adequate contact with the skin. Dual sequential defibrillation for refractory VF VS changing pad position. Refractory VF is defined as VF that does not respond to 3 or more standard defibrillation attempts. Case series have suggested that dual sequential defibrillation (DSD) may improve ROSC rates by adding a second set of defibrillator pads using a separate defibrillator, ensuring that pads are not touching each other, and defibrillating both machines within a second of each other. The 2020 DOVE-VF was a pilot study of 152 out-of-hospital cardiac arrests which compared standard care with either DSD or changing pad position, switching from anterior lateral to anterior posterior. ROSC was obtained in 25% of the standard care group, 39% of the vector change group, and 40% of the DSD group. It was unclear whether this will translate to improved neurological survival. This study suggests that changing pad position is as effective as dual sequential defibrillation. It is important to understand that DSD should not be employed for recurrent VF, a separate entity from refractory VF, PERL. Successful ROSC with dual sequential defibrillation, DSD, may be time-dependent, with greater success early in the resuscitation. If using DSD, start it immediately after the failed third shock. Also, ensure that the two defibrillators are on the same side of the patient while the compressor is on the opposite side so that sight lines are clear and team members do not trip on the defibrillator cables. Medications in cardiac arrest. In most cases, cardiac arrest is a pump malfunction problem, and currently not one that medications appear to have a major role in reversing outside of certain discrete causes, hyperkalemia. Hypocalcemia. Likewise, neurologic recovery is related to minimizing low flow to the brain and avoiding secondary insults. These goals currently appear to be best met with high-quality CPR and good ICU care. In 2022, there remains no high-quality evidence that any medication definitively improves long-term neurologic outcomes in cardiac arrest. Epinephrine in cardiac arrest improved ROSC, but what about neurologic outcomes? While epinephrine improves the rate ROSC in cardiac arrest and may improve survival, it has never been shown to definitely improve survival with good neurologic outcome at hospital discharge. The Paramedic 2 trial is the most robust epinephrine in cardiac arrest RCT. It randomized 8,014 adult out-of-hospital cardiac arrest patients to epinephrine 1 mg every 3 minutes versus placebo. The 30-day survival was improved with epinephrine, 3.2% vs 2.4%, but there was no difference in survival with good neurologic outcome. However, this may have been a power issue, especially looking at the longer-term outcomes. At 3 months, there were not enough patients alive to provide the statistical power to reliably detect a difference between groups. It may be that it takes a long time for the brain to recover, and if the study was powered for longer-term outcomes, there may have been a significant difference in survival with good neurologic outcome. Timing. 10 studies comparing early to late epinephrine uniformly found that earlier epinephrine was associated with better outcomes, particularly for patients with non-shockable rhythms. Dose: high-dose epinephrine, greater than or equal to 0.2 mg per kilogram or 5 mg bolus dose may improve the chances of ROSC, but does not appear to improve survival and has shown a trend towards more harm. Our experts usually limit epinephrine to 3 1 mg doses, especially in patients who have had VF or pulseless VT during their arrest. Infusion of epinephrine compared to bolus in experimental models suggests improved brain flow, but has never been shown to improve survival or neurologic outcomes in cardiac arrest. Is vasopressin better than epinephrine in cardiac arrest? A 2001 RCT comparing vasopressin versus epinephrine failed to detect any survival advantage for vasopressin. A 2013 study of vasopressin, steroids, and epinephrine for in-hospital cardiac arrest suggested that combined vasopressin, epinephrine, and methylprednisolone during CPR and stress-dose hydrocortisone in post-resuscitation shock, compared with epinephrine saline placebo, resulted in improved survival to hospital discharge with favorable neurological status. A 2019 Cochrane review found that vasopressin compared to epinephrine in out-of-hospital cardiac arrest improved survival to admission, but not ROSC rates. the largest trial in 2021 is one of in-hospital cardiac arrest patients comparing vasopressin and methylprednisolone versus placebo in patients who had received at least one dose of epinephrine. It found improved rates of ROSC. However, it found no significant effect in long-term survival or survival with favorable neurologic outcome. Bottom line, vasopressin may have an advantage over epinephrine to improve rates of ROSC and survival to hospital admission, but has not been shown to have any advantage over epinephrine for long-term survival or neurologic outcome. Vasopressin should be considered in patients with true vasoplegia according to our experts. Amiodarone or lidocaine for ventricular fibrillation and pulseless ventricular tachycardia. Amiodarone and lidocaine are considered equivalent in the treatment of ventricular fibrillation or pulseless ventricular tachycardia according to the ACLS guidelines. However, a recent reanalysis of the ALPS trial suggests otherwise. The ALPS RCT in 2016 compared amiodarone versus lidocaine versus placebo in OHCA patients with shock-resistant VF or pulseless VT. It found that neither amiodarone or lidocaine had a statistically significant benefit over placebo. However, there was a 3% difference in survival to discharge that was not statistically significant. In a subgroup analysis, amiodarone and lidocaine were better than placebo. However, more patients who received amiodarone required temporary pacing. In a 2022 Bayesian reanalysis of the ALPS trial, treatment with amiodarone had high probabilities of improved survival and neurological outcome, while treatment with lidocaine had a more modest benefit. In another 2022 reanalysis of the ALPS data, the probability of ROSC decreased as time to drug administration increased. The effect of amiodarone, but not lidocaine, to restore ROSC declined with longer times to drug administration. They attributed this to amiodarane's adverse hemodynamic effects. Bottom line, when given early in cardiac arrest, amiodarone may be better than lidocaine and placebo to improve rates of ROSC. Survival and neurologic outcome. Despite the ALPS trial failing to show a statistically significant benefit, pitfall, given that the earlier vasopressors and amiodarone are given after cardiac arrest, the more likely they are to be beneficial. A pitfall is to delay the administration of these drugs. Epinephrine or norepinephrine for post-ROSC shock. Despite the limitations of observational data, evidence continues to suggest that norepinephrine infusion may be preferred over epinephrine after ROSC is achieved in cardiac arrest patients. A 2021 retrospective review suggested that rates of ED refractory shock, rearrest and mortality were higher in patients who received epinephrine compared to norepinephrine after ROSC was achieved. A 2022 observational study in OHCA patients with post-resuscitative shock suggested that use of epinephrine was associated with higher all-cause and cardiovascular-specific mortality compared with norepinephrine infusion. These observational studies are difficult to interpret, as it is likely that the sicker patients were more likely to receive epinephrine. Bottom line, observational data suggest that norepinephrine is the preferred vasopressor for post-ROSC shock. Some experts recommend preparing a norepinephrine infusion, time permitting, before or during cardiac arrest resuscitation, so that as soon as post-ROSC shock is identified, the norepinephrine infusion can be initiated and titrated rapidly. Is there a role for sodium bicarbonate in prolonged cardiac arrest? Routine use of bicarb in cardiac arrest is not recommended in the ACLS guidelines, but should be considered in specific cases of ASA overdose, NA channel blockers with wide QRS complexes, TCA overdose, cocaine overdose, and hyperkalemia as potential causes of the cardiac arrest. In theory, raising the serum pH in cardiac arrest patients may be beneficial. On the other hand, bicarbonate does not improve the ability to defibrillate or improve survival rates in animals, can compromise coronary perfusion pressure, may cause adverse effects due to extracellular alkalosis, including shifting the oxyhemoglobin saturation curve or inhibiting the release of oxygen, may induce hyperosmolarity and hyponatremia, produces carbon dioxide, which is freely diffusible into myocardial and cerebral cells, paradoxically contributing to intracellular acidosis, and may inactivate simultaneously administered catecholamines. Some experts believe that bicarbonate has no role in a closed system such as cardiac arrest where excess CO2 cannot be exhaled because of venous arterial dissociation. A 2018 RCT suggested that bicarb in cardiac arrest with transient hyperventilation improves acid-base status without CO2 elevation, but that it had no effect on the rate of ROSC or good neurologic survival. A 2021 systematic review and meta-analysis of bicarb in out-of-hospital cardiac arrest, which included 4 RCTs, suggested that there was no benefit in survival at discharge or ROSC rate, and pooled estimate of 2 studies showed that bicarb was associated with less sustained ROSC and good neurological outcomes at discharge. There is some suggestion that in prolonged cardiac arrest sodium bicarbonate may have role, but there is no good RCT data to support this. A 2006 RCT of cardiac arrest patients given bicarb versus placebo found no difference in survival to ED admission, but did show a trend toward improved survival in those patients with prolonged cardiac arrest greater than 15 minutes. A small 2018 RCT in patients in cardiac arrest greater than 10 minutes, there was a significant rise in pH, but no improvement in survival to hospital admission or good neurologic outcome at 1 or 6 months. Bottom line, while the use of bicarb in cardiac arrest may improve acid-base status, it has never been shown to improve clinical outcomes and has many theoretical downsides. Bicarb should be reserved for patients suspected of ASA overdose, NA channel blocker overdose or hyperkalemia as a cause for their cardiac arrest, and it is still controversial for prolonged cardiac arrest greater than 15 minutes based on weak evidence and physiologic rationale. Is there a role for routine use of calcium in cardiac arrest? While administration of calcium may have inotropic and vasopressor effects, it does not appear to have a role for routine use in cardiac arrest. It may play a role when hyperkalemia, hypocalcemia, e.g., after multiple blood transfusions, or calcium channel blocker toxicity is suspected as a contributor to the cardiac arrest. The 2021 COCA RCT randomized 391 cardiac arrest patients to 4-or-IO calcium chloride vs normal saline immediately after the first dose of epinephrine and found that sustained ROSC was 19% in the calcium group vs 27% in the saline group, while survival at 30 days was 5.2% in the calcium group and 9.1% in the saline group, and favorable neurologic outcome was 3.6% in the calcium group vs 7.6% in the saline group. There was a trend towards more harm in the calcium group, but the trial was stopped early, so any definitive conclusion about benefit and harms are difficult to make. Bottom line, there is no role for routine administration of calcium in cardiac arrest. It should be reserved for those patients suspected of hyperkalemia, hypocalcemia, massive blood transfusion, or calcium channel blocker toxicity as a contributor to the arrest. Is there a role for Esmolol in refractory ventricular fibrillation? In refractory VF, there is a huge increase in sympathetic tone, at least partially due to the epinephrine given, which results in increased myocardial oxygen demand, exacerbation of myocardial ischemia, and depression of the VF threshold. Esmolol is an excellent sympatholytic and it increases the fibrillation threshold. It has the fastest onset and shortest half-life of any B blocker. There are no large RCTs for Esmolol in refractory VF. A tiny 2014 study compared 6 patients who received Esmolol after usual ACLS care with 19 controls who received usual ACLS care only. All 6 patients achieved ROSC after 500 micrograms per kilogram for bolus followed by a drip of a maximum of 100 micrograms per kilogram per minute, with 4 of them achieving sustained ROSC. Survival to discharge with a good neurologic outcome was 50% in the Esmolol group vs 11% in the control group. A 2016 retrospective study compared 16 out-of-hospital cardiac arrest patients who received Esmolol to 25 patients who did not, and there were no improved rates of ROSC or survival to the ICU. Bottom line: while Esmolol is not ready for routine use in refractory VF, it can be considered as part of the kitchen sink when nothing else is working. More importantly, epinephrine should be discontinued in refractory VF. Esmolol should be considered for both refractory VF and recurrent VF airway management in cardiac arrest. There has been a paradigm shift over the past 20 years from ABC to CAB for cardiac arrest resuscitation. High-quality chest compressions and early defibrillation should take priority over securing the airway. Pre-hospital intubation does not improve outcomes in OHCA. Once it has been established that defibrillation is not required and the first dose of epinephrine has been administered, it is a reasonable time to place a definitive airway during ongoing CPR. A pause in chest compression should never occur to help facilitate placement of an ET tube. Providers should be skilled at placing an ET tube during ongoing chest compressions, and if not, a supraglottic airway should be considered. Our experts believe that as long as end-tidal CO2 monitoring is employed and providers are experts at airway management, there is no convincing data to suggest a difference in outcomes between BVM, supraglottic airway, or ET tube. The data that suggest otherwise were limited by high rates of multiple attempts at intubation. The Airways 2 RCT suggested no difference in neurologically intact survival between supraglottic airway and ET tube. The supraglottic airway group was more likely to have successful ventilation after up to 2 attempts, 87.4% vs 79%, but also had a higher rate of loss of previously established airway, 11% vs 5%. An RCT out of France and Belgium showed no difference in 28-day survival between patients receiving BVM vs ET intubation. ROSC was higher with intubation, 38.9% vs 34.2%. 95% CI minus 8.8% to minus 0.5%, p equals 0.03. Adverse events were more common in BVM group: airway management difficulty, airway failure, 6.7% vs 2.1%. Regurgitation was more common in the BVM group, 15.2% vs 7.5%. The PART trial showed that placement of a supraglottic airway had better 72-hour survival and neurological outcomes compared to ET intubation. However, intubation skill was a big confounder in this study. First pass success was only 56% and 20% of points required 3 or more airway attempts. This study suggests that if intubation skills during ongoing chest compressions are limited, then a supraglottic airway may be preferable. A systematic review and meta-analysis comparing the effectiveness of different airway interventions during CPR in patients with OHCA suggested that supraglottic airway has better rates of ROSC compared to BVM or ET intubation. However, intubation success rates influence the results. If end-tidal CO2 is not available, a supraglottic airway or ET tube is recommended rather than BVM. Disadvantages of ongoing BVM for the duration of the cardiac arrest is that it often requires two providers to do. It effectively needs to be monitored carefully by the team leader and may not be the best use of provider utilization. How to prevent hyperventilation during cardiac arrest? Many providers are adrenalinized and tend to hyperventilate during cardiac arrest, which has deleterious effects on the patient's physiology. One strategy to prevent hyperventilation is to have the bagger say 1 Mississippi, 2 Mississippi, etc. between each breath delivered. Another is to place the patient on a ventilator early in the resuscitation, whenever feasible. Ketamine for sedation in cardiac arrest. Anecdotally, during CPR some patients appear to regain consciousness, chest compressions are stopped, and then they lose their pulse again. Ideally, the patient should not be aware of chest compressions if there is a possibility that they are regaining consciousness. It has therefore been suggested that dissociative dose ketamine be administered to patients in cardiac arrest after other high-priority tasks have been completed, so that they are not aware of chest compressions when they regain consciousness. Ketamine may also improve intubating conditions for patients who are going in and out of consciousness during the resuscitation. There is also a suggestion that ketamine may attenuate harmful cellular cascades after brain injury that result in permanent damage. Clinical trials are currently assessing whether ketamine sedation during cardiac arrest may improve neurologic outcomes. Post-arrest care. Once we've achieved ROSC, our job is not over. Good post-arrest care involves maintaining blood pressure and cerebral perfusion, adequate sedation, cooling and preventing hypothermia, considering antiarrhythmic medications, optimization of tissue oxygen delivery while avoiding hyperoxia, getting patients to PCI who need it, and looking for and treating the underlying cause, a novel approach to PEA arrest. The guidelines continue to recommend running through the HS and Ts in order to arrive at a specific diagnosis and guide treatment in PEA arrest. This approach may not be ideal because the HS and Ts are difficult to remember in the heat of a stressful resuscitation, and some of the HS and Ts' rare causes of PEA, hypoxia, hypokalemia and hyperglycemia, or are obvious, hypoxia, hypothermia. In contrast, the approach to PEA arrest proposed in the articles a simplified and structured teaching tool for the evaluation and management of pulseless electrical activity focuses on the more likely diagnoses that require immediate treatment beyond your CABS to achieve ROSC. This new way of thinking about PEA combines initial ECG morphology with the clinical scenario to guide the clinician to the most likely causes and offer further diagnostic certainty using point-of-care ultrasound. POCUS. The first key step is to distinguish between narrow complex and wide complex PEA, with POCUS being used to help differentiate the causes of narrow complex PEA in particular. Our experts caution that this approach should be used only when a highly skilled ultrasonographer is present and in a way that does not interrupt high-quality CCR. Ideally, a designated team member provides the specific POCUS role independent of the other team members. Antiarrhythmics in post-arrest care. While we know that intra-arrest antiarrhythmic medications may improve rates of ROSC in ventricular fibrillation, VF, and pulseless ventricular tachycardia, private arrests, there has never been a trial to show improvements in long-term survival with any antiarrhythmic medication when it comes to giving antiarrhythmic medication post-ROSC. There is only one RCT of lidocaine post-arrest, which showed a decrease in the incidence of recurrent VF. In this study, lidocaine was given both intra-arrest and continued post-ROSC. Hence, our experts recommend that if lidocaine is given intra-arrest and ROSC is achieved, then it is reasonable to continue a lidocaine infusion post-ROSC. The guidelines state that there is inadequate evidence to support the routine use of lidocaine after cardiac arrest. However, the initiation or continuation of lidocaine may be considered immediately after ROSC from cardiac arrest due to VF private. We will need to wait for the results of the ROCALPS trial to give us a more clear idea of whether or not we should be using antiarrhythmics intra-arrest or post-arrest when to terminate resuscitation. The only validated rule for termination of resuscitation is for the adult out-of-hospital cardiac arrest, and it has 3 pre-hospital variables for predicting a 1-month death after OHCA, no pre-hospital return of spontaneous circulation, unshockable initial rhythm. Unwitnessed by bystanders. In the ED, the decision to terminate resuscitation is multifactorial and there is no absolute time cut-off. Some of the factors to consider are age, comorbidities, ECHO 2 less than 10 after 20 minutes. If high-quality CPR, this factor should not be used in isolation for termination of resuscitation decisions. Initial VFib or recurrent VFib. Our experts recommend activating the cath lab ASAP with ongoing mechanical CPR for patients in recurrent VFib or VFib. Storm. Hypothermia. Hypothermic patients are not dead until they are warm and dead. What are the indications for cath lab activation in post-arrest care? The literature clearly shows that patients with an initial rhythm of VFIB or showing ongoing signs of STEMI on ECG should be considered for emergency PCI. Our experts believe that it is especially important to advocate for PCI in patients who suffer from recurrent VFib or VFIB storm. For all other patients, those without VFib or STEMI, it is unclear which patients should be transferred for PCI. One of our experts suggests that any patient in whom a cardiac cause is suspected and no other cause is apparent should be considered for emergency PCI. Again, similar to the decision to terminate resuscitation, multiple factors should be taken into consideration in deciding whether or not to activate the cath lab. Favorable factors include an elevated troponin. A ROC paper that is currently under peer review as of November 2015 shows a clear association between a higher serum troponin level and a PCI amenable lesion as well as improved outcomes. Unfavorable factors derived from the Utstein factors, non-VFib arrest, unwitnessed arrest, no ROSC in the field, age more than 85, clearly no cardiac cause, e.g. overdose, drowning, 30 minutes to ROSC, long resuscitation time without ROSC as indicated by acidosis, pH less than 7.2, and elevated lactate more than 7. Targeted temperature management in post-arrest care. The guidelines stipulate that targeted temperature management, TTM, should be initiated for all post-arrest patients who achieve a ROSC, and it's up to your intensivist what the target temperature should be between 32 and 36 degrees, TTM. Just do it. It is important to understand that the control arm in the TTM trial still actively cooled patients, just not to the same degree as the 32-degree arm. a pre-hospital RCT in 2013 compared immediate 2L boluses of cooled saline versus in-hospital cooling and showed an increased rate of rearrest and acute heart failure in the pre-hospital group that received immediate large boluses of cooled NS. Therefore, in terms of when and how to start cooling, Dr. Morrison recommends to wait a few minutes after ROSC to let the heart settle and then start cooled for saline in small boluses. The relative contraindications to TTM, excluded in clinical trials, intracranial event, hemorrhage, pregnancy. In closing, we have journeyed through every intricate detail of modern cardiac arrest management. From the rapid initiation of CPR and thoughtful application of advanced cardiac life support measures, through nuanced pharmaceutical choices, to the critical realm of post-resuscitation care and targeted temperature management. Along the way, we explored evolving concepts such as cardiocerebral resuscitation, the shift from ABC to CAB, the importance of continuous chest compressions and minimized pauses, the judicious use of medications, and the harnessing of emerging technologies like POCUS and mechanical compression devices. We learned that while no single magic bullet exists, excellence in fundamentals, timeliness, high-quality chest compressions, controlled ventilation, and careful patient-tailored interventions forms the backbone of improved survival and neurological outcomes.